Okay, well, perfect. Welcome, everyone, and thank you so much for joining us for another Brunch and Learn brought to you by The Qualified. My name is Japera Denson, and I will be serving as your host for today. I'm super excited for today's presentation. It's going to be a good one, so I hope that you are excited and expectant as well. But listen, before we get into today's presentation, we want to know a little bit more about those who are joining us today. So please do drop a welcome or a warm greeting in the chat. Let's get some interaction going here with our colleagues and with our peers. Let us know maybe even where you're joining us from, what region you're in, or what state you're joining us from, or if you're in another country, let us know what country you're joining us from too. So again, feel free to drop that in a chat and exercise and use the chat as much as possible for today. If you're a student, if you are a recent graduate, if you are a seasoned professional, if you're a coder, if you are an HIM manager, an HIM director, or anything within the health information profession, let us know that. Drop that in the chat as well. So tell us just a little bit about yourself, where you're from, and what you do so that we can get to know each other better. All right. So these Brunch and Learns are brought to us every single month by The Qualified. I want to share a little bit of information with you about The Qualified so that everyone knows who we are and what we do. These Brunch and Learn events are not only designed to provide you with outstanding continuing education opportunities, but we want to create this community and this space for people to connect with their peers and their colleagues. So again, for those who are just joining us, please do feel free to utilize the chat and let us know where you're joining from and what your professional status is. Student, recent graduate, coder, manager, director, educator, whatever you do, feel free to share. The Qualified is here to serve you in many, many ways, everyone, many, many ways. And so not only do we provide these types of ongoing educational opportunities, we call these Brunch and Learns, but we also provide tutoring. We provide online courses. We have exam certification prep courses available. We have so much more. And so we want you, even if you are an employer and you need help hiring some qualified or some certified professionals into your department, we want to help you with that as well. So we have services that we offer to a variety of organizations, professionals, students, a little bit of everybody, right? So please do check out our website. It's listed below in the bottom right corner, the-qualified.com. Check us out so that you can learn more about what we do, all right? All right, so listen, without any further ado, we are going to get right into today's presentation. Again, I'm super excited to welcome this young lady in. We have Mariah Hilton joining us today. She is located in the state of Florida, and I will allow her to share all of the goodness about herself with us. But please, everyone, let us welcome Mariah Hilton. She's going to be talking to us today about quality EHR documentation. Mariah, it's in your hands.
Okay, thank you so much, Japera. I do apologize. I was on video earlier, and for some reason now I'm not. I've played with all the settings, so I do apologize for that. So unfortunately, you can't see me. But if you go to the next slide, you'll see a picture of me. There I am. Ta-da! Okay, so just a little bit about me before we get into this presentation. So I've been working in healthcare for about 12 years now, and a good majority of it has been in the HIM field. I got my associates in health information technology from St. Petersburg College back in 2017. Kenjo was my program director. And then I followed that by earning my second bachelor's degree in health informatics and information management at the University of Central Florida in 2020. My first bachelor's way back in the day was actually in theater, so I'm kind of a second career person for HIM. I also have my credentials. I have the RHIA, the CDIP, and the CCS credentials from AHIMA, the American Health Information Management Association. I've also done a lot of volunteer work At the state level, the Florida Health Information Management Association, our FHIMA for the state of Florida here. And I actually just finished my term as a board director this past year, my two-year term. So that was really, really great volunteering. Really, there's a lot of great networking and learning a lot of new things. So if you don't volunteer, I strongly suggest you go out there. You'll be amazed by talking with your peers and what's new and what's upcoming. It's very, very good stuff. Now, over the 5 years, it's almost been a year now, but so 5 years, I worked as an HIM transcription technician for Sarasota Memorial Healthcare System here in Sarasota, Florida. And then right now, I am currently an outpatient coder for Baycare Health System there in the Tampa Bay area here in Florida as well, although I work 100% remote from home as a coder. Now, for the transcription technician role, this is where a lot of my experiences come into this presentation. Now, when you think about transcription or transcription technician, you're thinking like that you're typing up all of the dictation's voice files, you're editing, and you're getting that to the chart. As a transcription technician, though, that's not what I did. In my role, as a transcription technician, I really touched a lot of things. That role was kind of like an administrative function. So I did a lot of back-end things when it came to dictations, administrative functions for our dictation system. I also touched a lot of different areas. So I was really into analysis, chart completion suspension process, helping our coders in the coding department look for missing information or missing documentation. Any system upgrades, I participated in that in the testing. I also did, chart reviews and legal certifications when subpoenas were served for medical records. So in my position as a transcription technician, I did do a lot of touching in very different areas. And now as an outpatient coder, I do get a very different perspective on reviewing documentation. So for this presentation, the roadmap to quality E.H.R documentation, I got a lot of overall experiences that I'm going to be sharing with you today that I think is going to help us achieve some goals into getting that high quality documentation. Next slide, please. So some of my objectives for this presentation today. So we have had many advances in healthcare when it comes to obtaining high quality documentation. But I do believe that there are areas that we can assist and improve upon, especially with all of the evolution that we're getting with technology. I mean, technology changes every day. And so we're having to adapt constantly to all of this new stuff coming in. So I do think we have opportunities still out there that we can utilize to help get that high quality documentation. Now we're going to break it down. What we're going to start to do is break it down. We're going to go back to reviewing the basic fundamentals of documenting within an electronic health record, our E.H.R. And again, just offering some of my, from my personal experiences, I'm going to offer some insight and advice on how individuals in their departments can further assist on obtaining that high quality documentation that we're looking for from our providers. Now, while all the documentation in our E.H.R. and our health records, they're all very vital, they're all very important. For the focus of this presentation, we're going to stick to the most vital information in our health record, which is our physician and APP documentation. APP being advanced practicing professionals, so your physician assistants, your nurse practitioners, your certified nurse midwives, those documentations that treat the patient, and they're recording all of the information and the treatment provided, any procedures. We're going to focus on their documentation. Next slide, please. All right. So what is quality documentation? So according to some sources from the American Health Information Management Association, AHIMA, clinical documentation in a patient's record includes any and all documentation that relates to the care of the patient during the patient's stay or encounter. The clinical documentation in a patient's record forms the basis for the current and the future care of the patient by the healthcare provider. Now, high quality documentation should apply several characteristics, and that includes things like legibility, reliability, precision, completeness, consistency, clear, and definitely timeliness. And I really wanted to highlight this last statement here, this last sentence, because it is really, really important. Everyone involved with documenting or using, I should have put a little bit more emphasis on using here, health information is responsible for its quality. So it's not just on providers, okay, for quality documentation. It's not just on them. Yes, they are the main ones. They're the entering the documentation into the chart, and they're the ones that are actually recording the treatment to the patient. But anybody also who uses that health information is responsible for its quality. And that includes any and all of us that use it. So it's really, really important. So let's take a step back for a bit. Let's go do a little history here. Evolution of our clinical documentation. So yeah, we for many years we were on paper. And here's a lovely little image of what a paper looked like. By the way, none of my images are actual patient information. This image I did get from online, so no patient information is being seen. These are just complete examples, like a Jane Doe or test an account. So this is an image of what paper looked like, and as always, the handwriting is horrible. It's one thing that hasn't changed over the years is the physician's handwriting. So paper was really, really tough, right? The quality of the documentation, the legibility was really, really tough. So now as we're getting into electronic, we're starting to get a little better at things, right? So one fun fact that I thought was kind of cute was that our actual first EMR was created back in 1972. Whew, that's interesting because I really don't, I mean, granted, I wasn't born yet in 1972, but it's interesting to hear that the first EMR was created so far back then because you don't really have, I mean, the healthcare organizations really don't have experience with the EMRs until what was it, around the early 90s towards, yeah, thanks, Kendra, towards the early 90s. Mostly it didn't really start picking up, I would say, until the 2000s when the legal legislatures implemented wanting to get people on the electronic health record. So acceleration into the electronic health records began in the early 90s, and boy, has it been rapidly growing ever since. And like I said before, it's changing every single day. So we're seeing a lot of changes, a lot of rapid adaptability here. Now, even though we have this advancement into the electronic records, we still have what is called a hybrid system. So what a hybrid system is, it includes both paper and electronic, okay? Now, the reason we still have that is a variety of reasons. Now, a majority of it, your pertinent information, is electronic. What you kind of still see that's still in the paper format could be consent forms, other facility health records, so getting records from another facility or maybe like nursing home documentation, billing, financial information, those kind of things you tend to see more and still in the paper format so that we're scanning it into the system. So we still have hybrid systems out there. Now, a majority of the documentation, especially from physician and advanced practicing professionals, are in the E.H.R, okay? They are solely in there using the electronic format to enter documentation. Every once in a while, you might see paper. Definitely if you do outpatient surgery, sometimes the provider will bring in their like office H&P. If it's really, really quick and fast, you might get a paper H&P. That's very, very rare, but I have seen it happen a few times. And then, of course, anesthesiology, sometimes they are also on paper as well. If it's something, again, pretty quickly, they're using a paper version of assessment versus the electronic format. But a good majority of it is electronic. Next slide, please. So our two most common types of physician and APP documentation that we see in electronic health record, first being is what's called a structured note. In a structured note, it is pretty much a pre-built, full documented template that is within the E.H.R, that is created and embedded within the E.H.R. So some examples would be a full history and physical, your consults, your operative reports, discharge summaries, progress notes. All of that is pre-built, and it is broken down in sections. And what I mean by that, let's take apart a history and physical, right? Now, a majority of these templates do follow Joint Commission, CMS, state, and organization regulations. So for a history and physical, Joint Commission requires, you have your chief complaint, your HPI, your past medical, social, family history, your review systems, physical exam, assessment plan. Those are all sections that are specifically broken down in a structured note for the provider to fill out, because those are the required sections that needs to be within the document to follow the regulation. So it is broken down. Now, each section, it can be a free text box where they enter in information in each section, or it can be also like bringing in information from other sources. So an example would be labs or radiology reports. So what it kind of looks like is it's like if you want to see yesterday's labs, you can hit a radio button saying 24 hours prior, and it will bring up all of the labs that the patient had within the last 24 hours. You can go back days. Don't think it goes really past anything but beyond months. You want to hit the most recent stuff, so like maybe 17 to 14 days. But that would be an example of bringing in information from other sources. Now, opposite of a structured note are your free text notes. And that's pretty much, it is very straightforward, blank documents, just kind of like bringing up a Word document that is embedded within the electronic health record. And this just allows the providers to enter the information any way they want. They can create their own templates. They can just put in a quick little note, anything like that. It's pretty much fair game, just whatever they want to use it for as a free text note. Next slide, please. So here I brought up examples, not the greatest of examples from the internet, but to the left here is an example of a structured note. So that's what I mean, where it is broken down in sections. So you have your reason for visit, your HPI, any allergies. And if you look on the left-hand side of the image, you can probably also click on one of those sections and it can bring in information, as I said, like, the labs or radiology, anything like that. It can bring it into the note. And then compare that with the free text note on the right-hand side here, which again, they can do it however way they want. It's pretty much just blank Word document embedded within the E.H.R. And they can use it, they can input their own template any way they want, and then they will send it to the chart. Next slide, please. So now, how is the documentation specifically entered? What do they do? So first off, we still have traditional dictation out there, still in existence. So traditional dictation, the provider's calling in, right? They call into a specific phone number and they enter in all the prompt information that is needed, like the visit encounter ID number for the patient, the work type ID that identifies what type of document it is. So you're like your history and physical, discharge summary. your provider ID number, so it knows who exactly is dictating it, and so on and so forth. And then they just they'll get like this beep, and they start dictating their whole note. And then once they're done dictating, they will hit another number, and that ends it. They will get a confirmation number, and off it goes into the dictation system to be transcribed and edited before it crosses to the EMR. Now, typically, not 100%, but typically, the voice filing, the transcribing and editing, that's typically outsourced to a third-party company vendor for them to do. Now, any errors, corrections, or issues with a dictation, some examples for like an errors, like maybe it's a poor audio file, so there could be a lot of blanks within the document. So you're left with a bunch of blanks you're sending to the chart. Provider put in a wrong work type number. It's supposed to be an operative note, not an H&P. Any kind of issues, corrections, errors like that, and any other administrative functions, whether you're adding new work types, whether you're creating new rules for the transcription company or adding new people to the system, administrative functions like that typically is done by the healthcare organization itself. Now, while traditional dictation, it has lessened over the years, right? It was very, very popular and very, very big, that the providers can just dictate and then somebody else would go over and do all of the transcribing and editing and put it on the chart and they can just review it. It has lessened over the years, but it is still around, and reason being for that is provider preference. We'll get a little more into that a little later, but for the providers, it's just a choice of how they want to enter the documentation. So if they still want to do a dictated document, that's what they're going to do, and we still have it in healthcare organizations today. Now, the big, loving, new, fancy technology that's up and coming more and more and more over these years is voice recognition software. So the images I have on this screen are examples of Dragon Medical One, which is one of those different technologies of voice recognition software. You probably heard other ones as well, like M-Modal. I mean, even Siri and whatnot is a type of voice recognition software, right? So this method, the voice recognition software, it has definitely become the most popular among providers, and it is just growing in use in healthcare organizations. I mean, in my old organization at Sarasota Memorial, all of our new residents coming in, we didn't have them do any dictations or whatnot. We only told them, it's like, you're using the voice recognition software. That's it. You're using Dragon. So it is very popular. And the reason being is that it's meant to increase efficiency. It definitely has like easier usability for the providers. And of course, it increases timeliness of document entry. And with voice recognition software, they can just bring up a document. They're pressing that button on the microphone. They're dictating it. And as it's being dictated, they can see their whole dictation being put up right then and there. And then as soon as the provider just signs off on it, the document's right there, done. You're not waiting for it to be transcribed or anything like that. So it has increased in popularity for those reasons. Now, mainly, voice recognition software is maintained and managed by the healthcare organization's IT department. Now, we still, even though we have dictation, we have fancy voice recognition software, there is still the option for typing or writing, okay? It is very, very rare, but providers still have the option to type up information themselves if they want to. I've seen a couple of providers that still do that. And then also handwritten notes as well. As I mentioned earlier, sometimes if it's really, really quick, they might have to scribble down an assessment if it's an emergency. A lot of times you're going to see more handwritten notes in downtime protocols. So disaster situations. I mean, here in the state of Florida, we had Hurricane Ian. Pretty sure a lot of people, especially the hospital that I have across the street here, their fourth floor, their top floor caved in during Ian, and then their first floor flooded. So I don't think they were doing anything electronic at that time. They probably had to switch to paper documentation, and that's where you're going to see a lot of handwritten notes in those kind of downtime protocols, or if a system crashes or anything like that. The other thing that we still have, and it's mostly seen in emergency care departments, are medical scribes. And medical scribes, they're following the doctors around in the emergency department, and they're typing up all the information as the doctor is going and treating the patient and telling them, this is what the current chief complaint is. This is like the recent test results. They're just kind of scribing at the same time as the doctor is treating the patient. And they solely type. Okay, they don't do any dictation. They don't do any voice recognition software. For them, for medical scribes, it's all typing. Next slide, please. So now, who does quality documentation impact? Now, it's definitely more than what's on this slide. I do promise you that. I didn't want to go too much into it, but some of your top people that quality documentation impacts, I put in this slide. So, of course, first and foremost is your patient. If you don't have quality documentation on the chart as the provider is treating the patient, that can affect the patient themselves. Because what if, for an example, they put down the wrong medication, nurse goes in, looks at the note, and starts administering the patient wrong medication, and then we have issues. What if that patient has allergic reaction to that medication? All based off of just that one statement in the provider's document that was inaccurate. So it definitely affects the patient first and foremost. In the same example, it affects the clinical staff. How is the clinical staff going to keep treating the patient if there's inconsistent information throughout the entire patient's chart? They need to have that high quality documentation in order to continue high quality care to the patient. And you have compliance. So we are bound by compliance regulations in our quality documentation. It's not solely just how we treat the patients, but how we document it as well. There are regulations there in place that we have to have in order to meet our accreditations, our laws, our regulations. So you have your accreditation organizations, biggest one, Joint Commission. You have your state, federal laws and regulations. Hey, CMS has it. It's in their rules and it's online. You can look it up, and they have documentation regulations as well. Insurance companies, that's part of compliance as well. Healthcare, even the healthcare's own rules and regulations, the healthcare organization itself has their own rules and regulations. Now, doesn't typically stray too far from what you already have in the accreditation organizations and the state, federal laws and regulations. But they will have their own rules and regulations to how they want documentation either entered or how the provider should document. Good example with that is for an operative report. So an operative report per Joint Commission, they want it on the chart within 48 hours after the surgery is completed. In my old organization, we actually upped it. We didn't want to wait 48 hours. We decided to put in our rules and regulations. We want it 24 hours after the surgery's done. So that's a good example of how they, typically follow it, but they might become a little bit more stringent. So they have to follow that as well in order to meet that quality documentation. Of course, it affects us, the HIM coding department. We have to have that quality documentation, especially in coding. My goodness. If you document it wrong, we're coding it, we're billing it out, we're getting money for it. And if it turns out to be wrong, that hurts the facility, because then we're having to pay back money to the insurance companies because we billed for something that actually didn't happen. So it's very, very important that we get quality documentation. Revenue cycle. Now, revenue cycle is really, really big. Don't want to put everything in there, but you got for revenue cycle, again, your insurance companies, your billing, charity organizations. I mean, that's all part of revenue cycle that quality documentation can impact. Researchers, your clinical studies, your new and upcoming surgeries. You know, when you have that, you need quality documentation documenting every stage for research purposes. If you don't have it, you can screw up your entire research for any new drugs or any new procedures or anything like that. And then you'll start getting denied, and you know, providers won't be able to implement all of this new stuff that could potentially help patients down the line. So quality that's really big to have quality documentation for researchers. And then, of course, you know, any other health systems or entities, like I said, there's a whole other lot. I mean, you got like public health information, COVID, right? That's our biggest thing for the last few years. And you have to document all of that for, like, you know, vaccinations, signs and symptoms, anything like that. I mean, if a provider says patient tested positive for COVID in a chart, turns out it was wrong, and that goes off to like statistics, public health statistics and whatnot, and that just skews off all of our information. So you need to have that quality documentation in there. Registries, your trauma registries, birth registries, cancer registries, that all goes into as well for quality documentation. You have to have that, again, for measurement purposes, for population health. All of that is really important for that quality documentation does impact. So there's a lot out there that it does impact. So we have to have this high quality documentation. Next slide, please. So what do we already have in place? We do have quite a few practices already in place for quality documentation. So AHIMA states that HIM practices facilitate data stewardship by promoting the adoption of guidelines for data access, use, and control, as well as principles and guidelines for the standardization of content and definitions. Okay. So some of these pertinent HIM practices, that include, first and foremost, your data governance. Okay, we've all heard that. That is the foundation of information management rules, is your data governance. And it involves dedicated individuals that make information management decisions and develop a structure to enforce rules involving the technologies. That includes your E.H.R, your training and education, your auditing, and your compliance. You have your data standardizations, okay? So creating, utilizing, maintaining a data dictionary helps standardize definitions and ensures that consistent use, and also facilitates a common understanding of an organization's data quality when developing reports and analyzing information. You have your data capture, validation, and management. This helps create an environment where the integrity and quality of data is preserved. And then, of course, you have your data capture, analysis, and output. Okay, this section is where a lot of your critical thinking comes about, right? So it requires that critical thinking about healthcare performance expectations, and of course, from the measurement data. And this be able to draw informed conclusions to help improve patient outcomes, provide excellent care, reduce those negative rates like HACs, your hospital-acquired conditions, prevent adverse events, and standardize treatments using evidence-based measurement. So all of that is already currently in place for HIM practices, all of this different types of data. Next slide. So all that fancy talk, we've heard it a lot, right? So what exactly does that look like in a healthcare organization? Okay. You probably don't realize it if you're currently working in an HIM department, right? It's just part of it. So some of that includes is your data and chart analysis. So you're reviewing the chart for any missing documentation, right? So you're big things are your H&Ps, your operative reports, discharge summaries. That's missing. We're assigning deficiencies for that missing documentation. We're telling the providers, hey, we need this. This needs to be on the chart. It also includes your measurement rates, like your delinquency rates, your infection rates, compliance rates. And then you have the delinquent suspension process itself. So this is holding providers accountable for that missing documentation or information. So we're telling them, we're assigning them the deficiencies for this missing documentation. If they get to the point for a certain time frame that's decided by the healthcare organization itself, they pass that time frame. Hey, guess what? You're getting suspended. You're not going to be able to treat any more patients until you get this documentation on the chart. Okay. Chart reviews. Okay, we're reviewing documents to ensure that all of the pertinent documents have the accreditation and organization's rules and regulations compliance. Okay, so we're reviewing those documents to make sure we are compliant with everything that we're accredited to the laws, and to our own rules and regulations. Of course, structured notes, going back to the basic templated notes, they are being built according to those standards as well. Okay, we're not just creating it because the provider says so. We are reviewing it, and then we're putting it in place according to those standards. Your CDI departments, so your clinical documentation improvement departments, they are helping to resolve any ambiguous or unclear documentation, and that's going to assist with proper coding compliance. And within CDI departments, you also have what's called your physician champions. So we have select physicians in the organizations that understand what we're trying to assist with in resolving some of these documentation issues. So it's like a kind of like a peer-to-peer kind of thing. So we have the physician talking to other physicians, assisting with getting that quality and documentation and promoting it, that this is what we need. So that way we're not hounding the physicians all the time, right? And then of course, your constant, your orientation for new providers coming in, any ongoing trainings, any retrainings, your yearly retrainings for the organization, stuff like that. So all of that are current practices in place to help us get that quality documentation. Again, there's probably a lot more, but this is some of the main ones that you see within the HIM department. Next slide, please. So all that's well and good, but we still have issues that we are still facing today getting that quality documentation. First one being is what I like to call the efficiency versus quality battle. And what we're going to review is the different types, the copy, paste, copy forward, and the training of providers. Each of these elements we're going to go through in different slides here shortly. So we're going to expand on all of these. Your communication and training between departments, even within your own departments. I mean, if you're in a big healthcare organization and your HIM department could be divided in different sections. So operations is over here, CDI is over here, coding is over there. And sometimes communication and training is a little difficult, even within your own department. Limitations in and between computer systems. Okay, there's still limitations. And regardless of the advancement of technology, we still have limitations. Outpatient CDI. That's going to be something big we'll discuss here towards the end. And of course, what I think we can evolve what HIM can assist with helping the providers in getting that quality documentation. So like I said, we're going to go over each of these here. Next slide, please. Click again. Okay. So this efficiency versus quality battle. Now, the advancement that we've seen, like creating the structured documents, so it's broken down to make sure we have all the sections needed within a document, and providers just need to fill out every section. your voice recognition software that's been advancing. Like all of this is to help efficiency, right? To make it easier on them to get the documentation on this chart sooner rather than later. So this advancement of efficiency of document entry, it's just evolved as fast as technology itself, it seems sometimes, right? But since we've done all these initiatives for efficiency for our providers, I've just started noticing this trend over the years that providers are now just favoring quick efficiency over providing us that quality documentation we need. So now we're in what I think is called this battle of efficiency versus quality. So the first of that being is the copy paste copy forward. So click again for me. So the copy paste copy forward, what that is when you're copying forward clinical documentation and the process of copying existing text in the record and pasting it in a new destination. So in a nutshell, when a provider brings up a document, typically they have the option to bring forward previous information for them to be a little bit more efficient in reviewing the documentation, reviewing what's going on with the patient, and then adding on to the documentation from then on. And of course, providers do use this function. It helps save time when updating notes on an existing patient. And your biggest common example of this that you would see are progress notes on lengthy inpatient encounters. So if you have a patient that's been there over a month, I guarantee you every single day, providers using probably the copy paste copy forward so they can review the previous information and get it on the chart. Why is that an issue? Right? I mean, it saves time. It's allowing the providers to review information quickly. So what's the big deal of it, right? Well, here, let me provide you an example on the progress notes on the lengthy patient encounter. So my first example being, let's say a patient came in, presented with pneumonia. And in the history and physical, the attending physician stated that the patient also had sepsis, right? Infectious disease saw the patient same day, put in a consult, and said, oh, no, patient doesn't have sepsis. They do have pneumonia, but not sepsis. Now, as you're doing progress notes, that builds start beginning from the history and physical from the previous information, right? So the providers are looking at just the history and physical information that's coming in over their progress note. And now sepsis, because they decided to leave it in there, is now on every single progress note for that patient being in there for 15 days, which means you have 15 days worth of inaccurate information on a patient's chart. So that's a no-no, right? We can't have that. So that's actually putting a serious risk on not only to your documentation integrity, but it's also putting a serious risk on your patient, right? So it can have this feature can present a lot of serious medical and legal ramifications if it's not monitored and audited for proper use. Another good example, and some of these examples that I have can be a little funny. I mean, it's not funny because it's on a patient's chart, but when it comes across, it can be a little funny. So another example I have is for a patient. I worked at a behavioral health center for 4 years. It was my first job in healthcare. And we had a psychiatrist. He was a very nice man, but he didn't like the technology of the E.H.R very well. So one day, one of my coworkers tells me to come over and looks at his notes. That's like a month worth of notes on a patient. And she wants me to verify, can you read this? I think I'm reading this wrong. And so in a continuous statement from the copy, paste, copy forward that went over a month's worth of documentation from the psychiatrist states that the patient came in, he committed suicide a few weeks ago, but today he says he's feeling better. That's not okay, right? That's what poses a risk to our documentation integrity. This function, it could be used, it could be really helpful to our providers, yes, but it can also pose such a serious risk and be harmful in so many areas. So if your organization doesn't have a policy on the copy paste function that is built within your EHR, create one now. Like, get it on there and let your providers know exactly what needs to happen if they're going to use this function within their EHR. And this policy, it really should include how you will review and audit this function to ensure that it's being used appropriately. And again, educate your providers upfront and continuously over that. Click again. Personally, I would say just get rid of it. But I also don't want to get rid of what could be a good efficiency tool for providers if it's used properly. Next slide, please. All right. So the next section of the efficiency versus quality battle is what I like to call the blame game, and is mostly seen in when providers are using voice recognition software. So as we've evolved and started using voice recognition software, I started seeing these statements at the end of documentation from providers. And it's really become a pet peeve of mine because it's putting a lot of blame on something that shouldn't necessarily be there. So let's see what I'm talking about. Let's bring it up. It's going to be so annoying. Here's some examples. You know, this note was generated. Please excuse any errors or improper insertion. You know, any typing dictation errors. Please excuse the software program. It just keeps going and going and going. All of these different types of statements, seeing at it, okay? Seeing at the end of a document. And they're putting the blame on the technology, okay? Yeah, I see it all the time. But this is not okay, all right? You know, when we were back in paper and providers were writing all their documentation, it was their responsibility to ensure that their documentation was accurate, their handwriting was legible, and we can utilize it to treat the patient. Even with dictated documents, okay? Dictated documents will go to the chart after it's been processed by the dictation company, that third-party vendor. And it's still the responsibility of the provider to review their document, make sure that it is free of any errors, any inconsistent information, right? Before they final sign. Now with voice recognition software, we are seeing these statements at the end, and the providers just went ahead and start blaming the system. No third-party vendor that provides an organization with voice recognition software is guaranteeing 100% accuracy of their technology. Okay? Voices themselves are different, how we say things, how we enunciate things, accents, that's all different from person to person. Has it evolved to the point where we can utilize it and it's created efficiency? Yes, but it is not 100% accurate. You cannot blame the system for not reviewing your own documentation. And if a third-party vendor is saying they're providing 100% accuracy, find a new vendor, because we're not there yet. One day we will be, okay? As technology is advancing, sure, we will get that 100% accuracy across the board. Now we're still years away from that. I guarantee we'll get there at one point, but we're still years away. So it is the provider's still responsibility to ensure that their documentation is accurate before signing off. Strongly recommend that you start telling your providers that these statements at the end of their documents are not okay. You cannot blame a system for the errors of your own documentation when it's not guaranteed 100% accuracy. Next slide, please. So as a result that we're seeing all of this blaming of technology for their inaccurate documentation, these are some of the things we are now seeing because they're not reviewing their documentations beforehand. Some of these again are funny. Okay, so the first one here, chief complaint for an HPI. Patient comes in for electrocardiac castration in the outpatient setting. Boy, I didn't think it was coming in to completely cut off my heart. No, that's not okay. How are we supposed to code that? You know? Next example, chief complaint. Patient didn't have a bowel movement for 5 days. He's taken a lot of medications. He's had multiple doses of meds daily, but still no bowel movement, but he's very assy now. I'm sure the provider meant gassy, but the voice recognition software kind of dropped the G there. And so we know he got very assy now. That can be misconstrued as inappropriate documentation. Like, what if the patient saw that? He could misconstrue it thinking that the doctor is like making fun of him or saying that he's an irate patient. That can be misconstrued very, very easily. And this last one, patient states the dizziness, something happened, being neuropathy time, she laid flat occasionally with changing position. Well, something happened, and I guarantee it was probably an accent or the way the provider dictated something where it ended up being, instead of what he wanted to say, the voice recognition software came out with being neuropathy. Why is that such a big issue? Because neuropathy is a diagnosis, okay? If the coder is not looking right at the documentation, I mean, for computer-assisted coding programs, your CACs, if they're just picking up that terminology and the coder's like, okay, neuropathy is in there, let's code it. So now you're coding, you're billing for it, you're billing for the treatment of neuropathy, it's going out, it's going to your insurance companies. Sure, insurance company could deny because it's like, where did this neuropathy diagnosis come from? And then the patient's upset if they're looking at the documentation, and it's just opens up a whole can of worms just from that one misconstrued text of how he dictated it with the voice recognition software. So that's big, right? So again, when or even until the technology is guaranteed 100% accuracy for voice recognition, the accountability for that quality and accuracy of the document, now it doesn't fall fully on just the provider now, okay? It also falls on who uses the information. So every time we're seeing this, we need to take care of it as soon as possible. We need to be reaching out to the provider and asking them for an addendum or a correction or anything like that, because how we use it could result in negative consequences if we don't fix it. Next slide. Now, the training for your physicians and your APPs. Now, so training is really, really big, right? Especially as the physicians come right in the door. Now, a lot of your new hire orientation it's a lot of information, especially more so for your physicians and APPs, because they're not just learning about the organization, they're also learning about the clinical aspects, learning how to enter information, whether it be medications, orders, documentation. They have a lot more than your typical new hire does if you're say you're an administrative assistant. Now, I truly believe that HIM should have a presence in the orientation of new physicians and APPs if they aren't already, okay? You want to be there. You want to present yourself. This helps start the building of a relationship and a rapport with your providers up front, just being there and going through all of the training when it comes to documentation, And you want to train your providers on all of these HIM processes that can affect them. Okay. First thing being how to enter documentation to the E.H.R. So you want to train them dictation and your voice recognition software, or they choose one to type. They can do that as well. But you want to train them on how they can enter into the E.H.R. There are different documentation types that they can utilize. You know, your structured versus your free text. Your documentation compliance, okay, what they need to put into each document, when the document needs to be entered on the chart, okay, so HMPs need to be on there. Oh, I'm sorry. We got 3 minutes left. I guess I won't be able to tell any stories. Sorry about that. So what it needs, all right. Your organization's deficiency suspension process, they need to know, okay, if they're getting a deficiency, how they need to complete the deficiency, if they want to argue it, when is suspension days so they can get their documentation in before they get suspended. Your pros and cons for provider preference on document entry, right? So I mentioned this earlier, your pros and cons of, so why would a provider choose dictation over voice recognition software? Biggest preference is that with the dictation, all the provider has to do is review the document once it gets on the chart, when it's done from the third-party vendor transcription company, make sure it's accurate, and signs off. Difference being with a direct entry document where they use a structure-free text note of voice recognition software, they are solely responsible for making sure it looks pretty. Like, so the editing, so all the grammar, all of your punctuation, that different sections, they are responsible for that as they are doing their documentation. Now, some providers, you know, they want the efficiency part, and the dictation company, while it does delay timeliness of the documentation getting on the chart, they trust the transcription company to make sure it looks like a document, versus where the provider will have to take time and make sure that there's no errors, whether it's grammatically or punctuality or anything like that. So that's your biggest provider preference on why they would choose dictation versus voice recognition. And don't be afraid to can you go back, please? Sorry. Don't be afraid on how to inform them on how how HIM handles these processes on the back end. Okay. One of my biggest examples was I handled a queue. If a provider said he completed a document, it didn't completed a deficiency, sorry, it didn't automatically drop. It got thrown into a queue for us to review and make sure the document was there before the deficiency gets finally removed. So I tell the providers at every orientation, it's like, look, this queue is not monitored daily. It's not monitored every other day. It's monitored pretty much every half hour or an hour within the day. So you have to have your documentation on the chart before you complete that deficiency, because we do not see it anywhere. That deficiency is going back to you, and you're going to be responsible for that deficiency again. So don't be afraid to inform them on how we handle things. You also want to listen to your provider's needs, even if we can't necessarily provide what we can give them right then. May expand on this if I can get into it. You also want to recommend or promote having organization-wide reminders, any yearly refresher trainings regarding the HIM processes, or even new or refresher trainings on documentation quality. And don't be afraid to get real with them, okay? Doctors can be scary. You have to have thick skin with doctors, but it's okay to get real with them at the same time. I guarantee they'll respect you 100% more. And this helps build and create that relationship with your providers. And just be prepared in advance. You want to make sure you have the answers. I mean, obviously we don't have the answers. Just say that you will look into it or anything like that, but be prepared in advance with them. Okay. Next slide. So I have to try to wrap this up really quickly. I do apologize that I went over time. You want to have open communication and training in your healthcare organization's departments. You want to communicate with your teams. especially when there are updates in the systems that HIM can utilize and it can affect your HIM processes. You want to create those relationships with IT. It should not be limited to management only, right? And cross-training within the department, learning from each other, coding and operations teams. We can help each other, learn from each other to what we need to see in the chart for things to get done. And that can help improve, your quality documentation. It can reduce deficiencies, queries, and can increase productivity. So having that cross training is crucial. And you also want to tell your team to be investigators, be those critical thinkers. You don't want to don't be afraid to question anything that looks off. And you want to help, so this can help solve inconsistencies, promote the need for additional education trainings, and resolve documentation issues. Next slide. The limitations in between computer systems, despite the advancement of technology, we still encounter those limitations, especially across different systems. Sometimes systems don't communicate with each other. So as I mentioned earlier, you want to listen to your providers, right? You want to take notes from them, take notes from your team on some of the difficulties you might encounter. And you can present these limitation issues at any future system upgrade or implementation meetings to review and hopefully have a resolution in the future, even if it can't happen right now, right? You can still have it written down, be prepared, and you can still present it and hopefully work on it in the future and give that to your providers. And you also want to think outside the box to help your providers, right? I won't be able to get to this example, but go ahead and click through these slides. And if you just kind of read through these slides, it just shows an example. One of my examples that I had a limitation with a provider that I created for his dictated document. He preferred to dictate. A table couldn't go through from the transcription system to the E.H.R. Next slide. Yeah, keep going. So yeah, it would just be a bunch of numbers for this poor provider. Didn't even look like what it should have been, which was measurements. Next slide. So I improvised, and what I created, which is on the next slide. So for his document, I created what kind of looked like a table, wasn't an official table. That's what it looked like on the E.H.R. on the left. But what I had to give the transcription company to use in order for it to look that pretty was this little scattered little thing over here on the right. So it's situations like these, think outside the box and how you can help providers even with those limitations in the systems. Next slide. Outpatient CDI. Now, CDI you see more so for inpatient counters only. That's mainly because they want to do concurrent reviewing as the patient's in-house. Retrospective reviews is really, really tough, and that's why you don't see outpatient CDI a lot. It's there, it's just not as prevalent as inpatient CDI. But I strongly recommend pushing for that outpatient CDI because I think it can do vast improvements in quality documentation. Next slide. And these are just some of the benefits with an outpatient CDI department that you can have. Also, if you haven't done so already in your organization, for your CDI queries that you create, make it a suspendable offense. Make sure that is something that is on your delinquency suspension process, because that provides an additional accountability to get that ambiguous or inconsistent information resolved. Next slide. And of course, evolving what HIM can possibly assist with documentation. This is my personal opinion. It's probably not well liked. But as we've evolved from paper and dictated and now into direct entry, we had processes in place for paper on how to correct it. Now with electronic documentation, it seems like as soon as the provider signs off on it, there's nothing we can do about it. Or unless we're begging the provider to do an addendum. But I do think we can evolve our policies that we had in the past for handwritten and transcribed documents to direct entry E.H.R. documentations that will allow us to help the provider and getting errored information fixed within their documents, making those corrections. I think involving that will help assist our providers. It will help assist us in getting things taken care of sooner rather than later, and make things more efficient, especially on HIM side. Next slide. And that is my presentation today. Again, I do apologize for going over. It's a lot of information. These are just some key points to take away. If you have any questions, please reach out to the qualified. I'll be glad to answer those questions for you guys.
Absolutely. Thank you so much, Mariah, for this presentation that you provided. I think the information was great information, and I hate that you had to rush through that last part. I would have loved to given you the space to do like a part 2 or something so that this can continue. I think that people were enjoying the information and were being enriched by it as well. So thank you so much for sharing with us. I have skimmed through the chat and I do not see any questions for you in particular. So I think that may be it. But Mariah, quickly for you before everyone leaves, how can we all stay in contact with you? Or if people want to reach out and ask questions, how might they be able to do that?
Oh, okay. I can provide my current email in the chat, my work email. Feel free to shoot me an email with any questions you might have, and I will gladly answer them.
Wonderful. And please also take some attention to the chat box where we have there for you all, not only Mariah's contact information, but also some information about the CEU certificate that you will be receiving. There's also an evaluation that we will be providing to you as well via email, because we want to know how we can best serve you. Please do let us know if you have any ideas or suggestions for future topics that we could cover. Again, we want to be able to serve you all in the most effective way. On the screen showing right now are Mariah's references. So if you do want to just skim through those, you can. And I want to remind everyone to please connect with us on social media. We're on LinkedIn, we're on Facebook, Instagram, and YouTube. And we post some pretty fresh and good information on YouTube. So please make sure that you follow us on these social media platforms. Also, check out our website at the-qualified.com. We have another Brunch and Learn coming up next month on the 19th. And this one, or that one, will particularly feature James Donaher from 3M. He works with 3M. So he's going to be talking to us about ICD-10 PCS, and he has a 2-part series. But listen, before anyone logs out, I want you to take a pause real quick. If I had a microphone in my hand, I'd tap it and get everybody's attention, right? So listen, we want to do a free giveaway. This is going to be our first time doing this. We are wanting to give away 1 seat to next month's Brunch and Learn. So we have done a random selection, and our winner for next month's Brunch and Learn is Shireen Varghese. And Shireen, if I am mispronouncing your name, please do feel free to state it phonetically in the chat box. But Shireen Varghese is what I perceive the pronunciation to be. So Shireen, congratulations. Congratulations. We'll cue the sound effects, the applause sound effects right here. Cue that. All right. And all of the bells and dings. Congratulations. You have won a seat to next month's Brunch and Learn with James Donaher that is free on the Qualified. Ladies and gentlemen, please do make sure that you join us next month and for the rest of this year, where we will have continuing education opportunities available for you on a variety of topics. If you particularly are interested in speaking or presenting at a Brunch and Learn, then please do email us at events@thequalified.com. That email address is located at the bottom right of the screen. Shireen, we're going to be in contact with you and to provide you with information for your free seat. for next month's Brunch and Learn. And to everyone else, we hope to hear from you and see you again. Again, we also want you to connect with us on social media so that we can all stay in touch. Super huge shout out and thanks to our phenomenal speaker for today, Miss Mariah Phillips. Thank you so much, Mariah, for gracing us with your presence and with your wisdom. Huge shout out to the CEO and founder of The Qualified, Dr. Kendra Sabri. We give a shout out also to Julia Meyer working behind the scenes and making sure that everything is staying knit together. And last but not least, we thank you all for joining and for participating in these events every single month. Oh my God, we cannot do this without you. So thank you so much for your continued support. So long, everyone. We hope that you will have a phenomenal rest of your Thursday, and we will see you at the top. Bye-bye.